You'll have 12 minutes to do the exam. This is well more than enough time, and I genuinely mean that for you to do an abdominal exam.
I'm gonna feel really bad.
No. Where's the neuro? I could understand it takes 15 minutes. You have more than plenty of time to do an abdominal exam in 12 minutes. You want to make sure you tell your patient how to lie down. You want their head at your left end and their feet at your right end, so it's easier for you to access the liver and the spleen that way. And we don't go on both sides of the table. We'll just stay to the patient's right. You need to have your legs bent for me, please. Makes it easier to palpate and percuss the abdomen. They have to be bent for the exam. You'll eventually want their arms down at their side, but when you want the patient to disrobe or pull their clothes up, I typically have them do it themselves. I feel like it's more appropriate than doing it for them, especially if you and the patient are different genders. So can you go ahead and lift your shirt up to about your bra line, please, and unbutton your pants and bring them down to your hip bones. So that way we've got the full abdomen exposed. So then, arms at the sides, good. And then you're gonna just inspect the abdomen as we always do, so you're looking for scars. If you saw a scar, you would wanna note in centimeters how long it was, where it was. You're looking for striae, you're looking for any abnormal coloring. Is the stomach symmetrical? Is it flat? Is it distended? Is it obese? Are there varicosities? Anything we might see going on with the abdomen. So you're just observing. And your pertinent negatives are basically the last page of your PowerPoint. That big paragraph will cover everything that we say, or that we do today. So you can say that as you go through, or you can say it all at the end. Whatever you want to do is fine with me, okay? So first, you inspect, then you got to listen, you got to auscultate. We always auscultate before we percuss or palpate, because doing any of that can increase vowel sounds in the abdomen and give you like false positive vowel sounds. So always listen next. So we're going to listen in 4 quadrants. If we cut a line at the umbilicus, top and bottom, there's right and left upper quadrant and right and left lower quadrant, so you need to listen there at least once in each area. So for those of you who haven't listened to vowels, a vowel sound sounds like a gurgle. Like put that on YouTube, I don't care.
It's going.
Once you hear a vowel sound, you can move on to the next quadrant. You don't need to stay there for a standard amount of time to hear how many vowel sounds and how many seconds you hear. You have up to 2 minutes though. If someone's vowel seems a little sluggish, you can give it up to 2 minutes to listen for vowel sounds. After that, if you still don't hear anything, that's hypoactive vowel, right? We listen with the diaphragm when we listen to the vowel sounds. Okay? I'm just going to listen to your tummy and let your patient know what you're doing. It's very clear. Here's alive. You're doing well. And then we're going to listen to the aorta, the renal, and the iliac arteries. So to listen to the arteries, you listen to the bell. You're listening for bruits, just like we listen for the carotid bruits. You shouldn't hear anything, ideally, right? Normally you wouldn't hear anything. The aorta is located about 2 inches above the umbilicus, directly midline. The renal arteries are just 2 inches on either side of that. The exact same line as the aorta, just 2 inches out. Make sense? And then the iliac arteries basically are 2 inches below and 2 inches lateral to the umbilicus on either side. So the renal and the iliac arteries kind of make a square, 2 inches above and 2 inches below, 2 inches to each side. So that's pretty easy. So we're going to listen with the bell for that. You shouldn't hear anything. I'd give it like 3 to 5 seconds just to make sure you don't hear anything.
Hear like a pulse or anything?
No, I don't. In very thin people, you may hear the pulse of the aorta, but you should not hear bruits.
You can see it, like sometimes.
Yeah, because you're very thin, yeah. I can feel mine when I lay down, too. That's normal.
Then that's okay.
Yeah, that's fine. Any questions over auscultation?
It just for future, if you hear it, if you hear the heartbeat, that's okay. It's just if you hear the bruits,
Right.
that's
Bruits like a sound of blood being rushed through the capillaries, atherosclerotic or narrowed.
okay.
Right? Okay, so then we're going to percuss. Hopefully there's nothing else I want to tell you about that. So percussing is just like you learn how to percuss on the lungs, on the chest. Yeah.
hear anything, or is there any way to tell on the physical exam if they have an abdominal aneurysm?
Yes. Okay, I'll show you.
Okay, proceed.
Proceed. All right. Thank you, Sarah. I'm gonna percuss. It's just like on the chest. One hand will be pressed firmly into the abdomen. On a thinner patient, you don't have to take out the slack of the skin so much, but on a larger abdomen, you will need to put a little bit of pressure down with your hand to take out the slack. It gives you a much better tympanic sound. So if you're going all over the abdomen and it feels dull, you may not be pressing hard enough. So I would try pressing a little bit harder. You're going to make 2 circles, one around the perimeter of the abdomen, the other periumbilical. And you just want to make sure you've covered all those 9 gastric areas. Right? So I'm going to tap on your tummy. Please let me know if anything's tender, okay? So here, nice and tympanic. That's a little dull. That's a little dull. So when they're not in pain and it's dull, that's cool. Now I'm going around the umbilicus.
So you're saying you're doing a big circle and then a small
Big circle and then a small circle, exactly. Okay, and that wasn't tender to her, so that was fine. And we'll percuss the liver and the spleen as well. When you do the liver, you need to percuss mid-clavicular line and mid-sternal line. Right, so we always start about an inch or so above the umbilicus because we don't know how big our patient's liver is. It could be enlarged. I imagine hers isn't, but we don't know. Right, so you're looking to hear tympanic sounds, and then it'll turn to dullness when you get over the liver, and then it'll turn back to resonance, or more of a tympanic sound once you're just over the lung and no longer over the liver. Okay. Again, I'm going to tap.
So, sorry, where are you starting?
Mid-clavicular, about an inch above your belly button. Okay? You can let me know if anything's tender. And I'm moving my finger up about 1 finger breadth at a time, so I want to make sure that I cover all of that tissue, right? And when we get over the rib cage, make sure that your fingers are between the ribs. You can have kind of a duller sound if you're percussing over a rib rather than between. You want to be in the intercostal spaces, okay? So see, that's duller. So you need to pay attention to where you start to hear the dull sound, and you'll need to just like visually mark where the liver is because you'll need to measure it with something that you bring in centimeters. And then I just continue up in her intercostal spaces. And it sounded more tympanic. I don't know if you're able to hear it from your phones. So her liver is this size. So then you can use one of these little Maxwell measurements, or I have like a little tape measure. Just measure in centimeters. So she is 10 centimeters. So what's normal for mid-clavicular liver?
10 to 12 or something.
6 to 12, right. So you're perfectly normal. So then we're going to do the same thing mid-sternal line. Still start down a little bit lower in the abdomen because you don't know if she has hepatomegaly or not. Keep going until it becomes tympanic. It's hard for you to hear. It's much smaller in this region. It wants to hide under the xiphoid as well, so it's just a little more challenging to hear, but you will hear it. 5 centimeters, so what's normal for mid-sternal?
I can't remember.
4 to 8. So she's, again, normal liver size. Then we can percuss the spleen, and this is something, I'll show you trough space first, because have you learned that already? Yeah, right. So you go to the last intercostal space of the anterior rib cage, right? So everyone's rib cage is shaped differently, so I'd encourage you to just figure out the outline of your patient's rib cage and come up and find that last intercostal space. Nice and tympanic. Have her take a deep breath in and hold. Still tympanic, so no spleen has moved into that space, causing it to sound dull. It's nice and filled with air. So that's trough space is negative. The other way you can percuss the spleen to know where it is typically it hides between the anterior axillary line and the posterior axillary line in the rib cage. So what we're going to do is percuss in this area along the ribs, and we're going to percuss from anterior to posterior, just in little bands down the rib cage, and you'll hear it go from tympanic to dull to tympanic again. And you can get an idea sort of where the spleen is sitting and if it's enlarged or not. So it's usually like hockey puck sized, you know, anywhere from 5 to 7 centimeters in length by 2 to 4 centimeters in width. If you don't hear it, you might not. It's challenging. It does kind of get a little loud in here. Don't get frustrated. We just want to see that you are doing it correctly. And, you know, learning the difference between dullness and timpani comes with practice. So I just encourage you to practice. So find the anterior axillary line. The other challenge is to remember the ribs run at an angle at this point. So you want to make sure that your finger's in the intercostal space, because if you're lying on the rib, it might sound duller than it actually is. And we're just going to go front to back. So that's dull. I don't know if you can hear. It's a little hard to hear. It's a little awkward, and it goes back to timpani. So she had like a 2.5 centimeter piece just right here that was dull. So then I'll just come down again in the intercostal space. And if this is hard for you because you're short like me, I would tell your patient to scooch over closer to the bed frame. It'll make it easier. So essentially, no, there's a little timpani, or a little dullness right there. You're just trying to get a general idea of where it is. I don't know if you need to report this in your pertinent negatives or not. It's not listed in your pertinent negatives, but we need to ask Dr. Cronin just to be sure. Okay, so that's all for percussion. Any questions? Okay, so then we'll palpate. When you palpate, your dominant hand will go on the abdomen, your non-dominant hand will go on top of that hand. When you start, obviously let me know when you palpating off. Please let me know when it's tender. I want you to go light to deep in the same spot. Don't do light all over the abdomen and then deep all over the abdomen. And I'll usually start right here, and you just go all the way around the perimeter, and then if you know, around periumbilically if you miss anything. I tend to put my hand flat on the stomach, and I kind of make kneading motions back and forth. And I start light, and you want to go slow. The slower you go, the easier it is to go deep, rather than just kind of going right in there. It's uncomfortable. People have more of a tendency to guard and not let you palpate. You're also wanting the tissue to run underneath your hands. So you feel the difference between skin, muscle. You'll feel bowel. It'll feel like like a rope, sort of, underneath your hands that's soft and movable. You might feel stool. And obviously we're feeling any firm masses or anything that's tender to her. And then I just move over to the next location. Make sure you check your patient's face each time you move to a new spot, because something may be uncomfortable, but not uncomfortable enough that she cries out in pain. So I just want to check if she's grimacing or not, right? She's not. So we start light, and then we move all the way to deep. And we just slowly go around the abdomen doing that. And I do feel her small bowel, but none of that's tender, right? Curd a little bit. And I'll just go around the umbilicus. Any parts that I might have missed. Okay. Now I have to palpate the liver and the spleen as well. So you're going to put your left hand underneath the rib cage and have her relax.
I have a quick question. When
Yeah.
you did the palpation, did you do the 9 areas, or you just kind of?
I went all over those 9 areas, but I really kind of went in a circle. I did not count. And again, that's why I like to move my hands back and forth, is because the tissue's then running underneath my hands, and I kind of like have covered all of that area. But I did not go 1, 2, 3, 4, 5, 6, 7, 8, 9. I went more in a circular fashion. Okay? So place your hand under the patient's left rib cage and relax. You're going to use that to pull her up to you a little bit, or your patient up to you. The liver does sit right under the border of the rib cage. So in thinner patients, you should be able to palpate it, or you may be able to palpate it right here, and you might not have to have me do any extra breathing. And I can feel her liver, and it's nice and smooth, and that's not tender to her. However, if I didn't feel it, or if she was a little bit larger, then I'd have her do some breathing, so I could get a chance to feel it better. So can you take a deep breath in for me, and exhale. When they exhale, you go under the rib cage, and one more breath in. That's when I feel the liver's being pushed down when she breathes in and out. Good. And so I'm using this part of my fingers when I go under. That's what I feel best with. I don't really feel the liver here. So when I'm feeling, I want to make sure that I move my hand with that part under all areas of the rib cage, because that's where I feel best. Does that make sense? Same thing with the spleen. For this, the spleen's not tucked right here under the border of the rib cage, so I do need you to breathe in and out and back in again because it's way back here. And when she breathes in, it pushes it down and in front, right? So we need her to do that. So you're going to stand on the same side, take the rib cage again, just relax, you can stay put. For this, since we have to go a little bit deeper under the rib cage, it's not a knife edge like we do with the liver, because I need to get back here.